Just hold on for a second, it's not ready yet. You can start.
Good evening, all. Welcome to the special event arranged by the Wellness Center. So we have two leading experts on the topic which is going to be discussed today. So as you're aware, there are a series of activities that are arranged by the Wellness Center. So this is one such activity, and I thank both the panelists, and also we have two experts from the Wellness Committee also in this panel discussion. And Dr. Vishwesha Guttal is going to anchor the session, and he will be introducing the speakers. So we are looking forward for this session. Over to you, Vishwesha.
Thank you, Anil Kumar. My name is Vishwesha. I'm a member of the IISc Wellness Center Committee. It's my great pleasure and honor to welcome you all for this event. Today, I know we have really distinguished panelists who will discuss an extremely important topic on prevention of suicides, which we all know is an extremely important topic in the context of higher education in India as well as more generally. I will introduce the speakers and the panelists today. Before I do so, let me make a few remarks. First and foremost, this session is being recorded, and it will be shared on the IISc Wellness Center website once we receive final consent from all the panelists. And so many of you may have questions during the presentations as well as post presentations. So you should feel free to post the questions using the Q&A option on the on the screen, and we will take these questions. However, we have already received a whole bunch of questions via the forms we had circulated over this week. So we will take the questions that we have already received on priority as well as the ones we received. Okay, and and then with that short remarks, let me introduce the keynote speakers today. It's my great pleasure to welcome Dr. Lakshmi Vijaykumar. Okay, Dr. Lakshmi Vijaykumar is an internationally acclaimed researcher in the field of suicides and prevention of suicides. It is our honor and pleasure that she has agreed to our invitation and is present here with us today. It is not possible to introduce her accomplishments in a short period of time. She has a very large number of years of experiences, and she founded the very, very well-known and acclaimed Sneha, based in Chennai, which is India's premier suicide prevention center. She was instrumental in inclusion of suicide prevention in National Mental Health Policy of India, played a key role in the decriminalization of attempted suicides. She has been a member of many international networks that have tried to do research on suicides as well as how to prevent, what are the preventive strategies. And in fact, while having conversations with her, I discovered that the Suicide Prevention Day, which is organized on September 10th every year, was one of her initiatives. It was through her initiatives and campaigning that the UN recognized it as an important to observe and to sort of create awareness. And it has, over the last decade or so, it has really picked up really amazingly across the world. It's celebrated, it sort of is observed in more than hundreds of countries. With more than millions of participants who try to understand and the causes as well as consequences of suicide. How do we prevent? So she has obviously been awarded a number of awards for her work. So I will not go through all of those details. She is currently an honorary associate professor in the University of Melbourne and an adjunct professor at the University of Griffith. And with that short note, I welcome Dr. Lakshmi Vijaykumar again. She's our first panelist. The second panelist for keynote speaker for today is Dr. Abhay Matkar. He is the professor and chair of Department of Psychiatry at SDM College, Medical College and Hospital in Dharwar. And he has been a past president of IMA Hubli chapter. He's also been the past president of Indian Psychiatrists Society, Karnataka chapter. And he has been taken a number of initiatives to sort of destigmatize mental health issues and written a number of articles that is aimed at popular audience, and he has won numerous awards in this context. It is again my pleasure to welcome Dr. Abhay Matkar to this panel. So in addition to two panelists who will present keynote addresses today, we also have three panelists who are part of our Wellness Center advisory committee as well. So what I will now do is I will hand over to Dr. Lakshmi for her presentation. We will then have a presentation by Dr. Abhay Matkar. And at the end of those, I will also introduce the other three panelists, and we will take questions that have come from all of you to all the panelists. So now I invite Dr. Lakshmi Vijaykumar to take over and do a presentation. Dr. Lakshmi, could you please share your PowerPoint?
Yes, please. Thank you very much for the introduction and the welcome. Is my screen visible for all of you?
Yes, 1 second.
Dr. Lakshmi, it's visible.
Okay, great.
Just 1 second, 1 second. I have to make sure the slides also go online. Okay, now it's send live. Nilay or Shekhar, can you make sure on the side Dr. Lakshmi is visible? Is it possible? How do we do that?
It is on my screen. Is it visible for you? No.
Just 1 second. Okay. Just once, give me 1 minute. I'll make sure. Okay, now I think it's in a good shape. I think the audience must now be able to see both the slides as well as a small video of you speaking. Okay, so please go ahead, Dr. Lakshmi.
Thank you very much. Thank you very much for the kind introduction, and thank you for this invitation, which I really look forward to interacting with students, because it's always enthusing to interact with students and learn from them, because I have learned a lot of things from young people with their innovative ideas, and I hope this is one such occasion where I also learn as much. So this is the suicide map of the world, and as you can see, unfortunately, India is one of the countries which have high suicide rates, along with a large part of Europe, Eastern Europe, Russia, and a few other countries. So we have really a high suicide rate in India. And if you look at the suicide rate of the young people, in all over the world, suicide ranks as the #1 cause for death for females aged between 15 and 19 years. So young women, the major cause for death for women all over the world is suicide. And if you look at our own country, India, you can see that between 15 and 29 years for females, between 15 and 39, I would say, the major rank of suicidal death is #1. So more than motorcycle accidents. Okay, and when you combine both female and male also, between 15 to 29 years, suicide death is ranks #1. So it is not just merely a loss of a young person to the family, but it is a loss to the society, it's a loss to the economy, it is loss of the future of India. So what exactly is the problem? So this is based on a very conservative estimate from the National Crime Records Bureau, where we say that there are about 1,35,000 suicides a year. Okay. Now we give a 15-20% under reporting, which becomes 1,60,000. for every suicide, it is estimated that there are at least 20 people who attempt suicide. Okay, and every suicide attempt or suicide affects at least 6 people, friends, family, colleagues around them. So if you really do the math, in our country, 1 in 65 people would be affected or by a suicide of a close person every year. This is the enormity of the problem. When we look at young people, this is a very interesting study which looked at what are the trajectories of suicide which happens between the young people between 15 and 24. And they have followed up these people for over 15 years, 20 years. And 3 categories have emerged. One is the group 1, who have long-standing behavioral problems, right from school, family, exposure to violence and everything. Then there is another group which probably they develop a psychological disorder during the adolescence, okay, and develop suicidal group. And the third group who do not have majorly any issue at all, but suddenly there is an acute crisis, acute stress, like an exam failure or a girlfriend leaving or whatever it is, and unable to handle that life event. Okay, so if you put a life chart of a person who belongs to group 1, you can see so many events there, no? Right from young age, from lowest birth weight to parents separated, reading problems, frequent shifting of homes, so on. No, all those triangles, it's very, very dense. Whereas if you take the group 3 person who really didn't have any problem, but just suddenly had an acute stress and unable to go, you will find that it was just it was all clustered in the last few months of life. Okay, and there was basically no other issues in the early part of life. So there was a study to find out, whether it is the individual vulnerability which causes suicide, or whether it is the society which pushes a person to suicide, has divided and dichotomized our thinking about suicide. It is neither this nor that. It is always a combination of both. And Gustav Turuki actually did a calculation and came out with the fact that a lot of biological factors like family history of suicide, family history of mental health disorder, lowered serotonin, all of that contributed to about 42% of suicidal risk. But the rest 58% is purely environmental. What are the psychological factors? In an adolescent and young people, we don't find the classic depression and so on and on. It is more an emotional state, depressed mood, very angry. Majority of them are angry, hostile, irritability. And if there are 2 issues which produces a lot of suicidal trigger in young people, it is shame. Something which brings shame in front of other people. It is an emotional state which they are not able to handle at all. Coupled with impulsivity, and of late we have also found that people who are extremely ambitious and perfectionist, who are not able to handle any failure or handle any imperfection, also have a lot of suicidal thoughts. And this is the age where sexual identity confusion emerges, and that becomes a trigger for suicide also. So substance abuse is very, very commonly associated with youth suicidal behavior. We don't have to be chronic abusers. What we have found is even adolescents who normally don't take alcohol, take alcohol when they make a suicide attempt. So 1/3 of suicidal attempts happen under the influence of alcohol. And what we find is that the initiation of alcohol in India has really started at age 13. Okay, these are all the factors which are been associated with suicide in young people, early onset of alcohol or other substance abuse, marijuana abuse. Unfortunately, many of the students think that marijuana has no major psychological, does not cause major psychological impairment. But what has research has shown is that even if you have smoked only a few times before the age of 16 or 17, the chances of you having a suicidal attempt is much more than a person who started smoking marijuana after 18 or 19. So somebody who started using marijuana before the age of 18 is at a far higher risk than somebody who, even if it is just a few times, 2 or 3 times, is at a far higher risk than a person who starts smoking marijuana later. What are the stress faced by students? If you have to categorize, it is in the domain of family, peers, friends, and in the educational environment. Okay, and these are all the stress which are usually faced by a student who is suicidal. I don't want to go too much into it because I'm sure all of you know about it. But one thing which really upsets a young person is rejection. Rejection by a person whom they care about, rejection, rejection to of a person's love or whatever it is, rejection of affection, that causes a huge sense of failure, reduces self-esteem, and a lot of suicide happens. So rejection and shame are two major factors which play a role in student suicide. So what are those symptoms of distress? Usually there will be a decline in academic work, stopping of usual activities, and there will be a lot of oppositional behavior, acting out behavior, risk-taking behavior. People will go and develop all kinds of hello, am I audible?
Yes, Dr. Lakshmi. Yeah, you're audible. Yes.
Yeah, my screen sharing has stopped. I don't know because
We are able to see your screen symptoms of distress right now.
I am able to see somebody else's screen, but not mine. But I am back again. Are you able to see my screen now?
Yes. Yes, absolutely.
Okay.
Yeah.
Okay. What are the environmental factors? I just want to highlight a couple of things. Okay. If you compare between boys and girls, girls are more physically and sexually abused. But if a boy is physically and sexually abused, he has a higher risk than girls. Same way, binge drinking is common in boys than girls. But if a girl binge drinks, her risk of suicide is more than a boy who binge drinks. Okay. Same way, for a boy, reduced peer support increases suicide risk. Whereas for girls, it is social isolation. Okay. Now, for early sexuality, if there is an early sexuality, boys make more attempts, girls have more suicidal ideas but not attempts. Okay, and when there is bullying, a reduced family support or neglect, it is more or less similar between young men and young women. Okay, and in victimization, direct victimization, that is somebody coming and hitting you or somebody in front of people or something, affects the boys more. It doesn't affect the girls more. For the girls, it is indirect victimization. If a group of girls decide that you are not part of the group anymore, that kind of victimization affects the girls much more than the boys. And this is a slide which I would like to share, which shows that there is a increase in suicidal ideation proportional to internet addiction. The more and more you are addicted to the internet, the more and more you are likely to have suicidal ideation. But then again, I would like to highlight the importance of the media. The media has a significant impact, particularly on young people. I'm sure most of you have seen this Netflix serial, which is called 13 Reasons Why, which is, it is a videotape. Each episode is a videotape of a young girl, who gives a reason as to why she wants to die, and the last episode when shows her actual death, and it is so graphically represented there that many of us wrote, and they have toned down the last episode, but it is still there. Anyway, see, people say that media does not have a role, but I just wanted to show you that after this Netflix serial, you can see that people in the younger age group, there is a 12% increase in boys. But what is even more interesting is that there is a 21.74% increase in suicidal attempt in females between 10 and 19 years, and majority of them have seen this Netflix serial. So that is the impact of the media. And more so if it is a celebrity suicide. For example, following the Robin Williams suicide, there was a 10% increase. And actually after this Kate Spade and Anthony Bourdain, there has been an 18% increase. And I am not able to tell you now, but we have done a kind of a Google trend search following Sushant's suicide, and there is a substantial increase. So when students are in distress, why do they have difficulty in asking for help? First is, it is very difficult for youngsters to ask for help, okay? And most of the time when they ask for help or talk about any suicidal thing, it angers the others. The other thing is, even they are not able to describe what they are going through. And they are not sure what kind of help will be available, okay? And the fear and the shame all causes problems. So actually majority of them confide to peers, and the peers normally are not able to help them in such a way that they are able to get professional help or family help or societal help. At the best, they are able to give an active listening, which is extremely good, but they must have the skills to understand, identify, support and refer, which is what we are hoping to teach the peer students and peer counselors, and and what we call as QPR, which is question, persuade and refer. And then why do we also hesitate to help? Because we don't know how to help, first of all, and we don't know whether we are saying the right thing or wrong thing. And then we feel inadequate to deal with this idea, and feel that, see, most of the time we feel that suicide cannot be, what we call as a bystander effect. But yes, we think suicide is an individual person's capacity. What can you and I do to change that? Or we think suicide is due to some poverty, unemployment. I can't do anything about it. So you feel that you can't do anything about and prevent suicide. But the fact is, for every suicide, there is always another option. Okay, let me give you a few examples of what we have done in terms of working with the young people. We know every year there are at least about 2,600, 2,700 young people who die by suicide because they have failed in exams. So, and then we did a small study and found that those who have failed in 1 or 2 subjects, or those who expected 90s and got 80s, were the people who died by suicide. But 60% of them were people who just missed in 1 subject or 2 subjects by a few marks. So armed with this and with the help of media, we actually did a media blitzkrieg. We convinced the government of Tamil Nadu to issue a GO, and the government of Tamil Nadu was the first government to initiate the supplemental exam, where a failed candidate can write the exam within a month or two, so that no academic year is lost and the student can continue with the academic process. And you can see from the inception of this, 2004 to 2018, the number of exam failure suicides in Tamil Nadu and Chennai have halved. There has been a half of what it was, and that this process has been, our intervention has been written about in the Economist, World Economist, and many countries, many states, surrounding states like Maharashtra, and I'm not sure about Karnataka, but some of the other states have also started the supplemental exam. We are trying to make it all India phenomenon, but I believe education at the school level is a state, and so we have to work with all the states independently. So when a student feels, or when a young person feels, okay, what are the kind of feelings they have? They feel desperate, they feel worthless, angry, lonely, guilty, sad, and all that. So what are the actions they do? You'll find many youngsters giving away a favorite guitar, a favorite tennis racket, whatever it is. They withdraw, they use substance abuse, they take unnecessary risk, okay? They have extreme mood swings, they have impulsivity, okay? And what are the thoughts which they do? They have, my problems will be over, I can't take it anymore, okay? I can't do anything right. And physically, they will have change in appetite, weight, sleep patterns, lack of interest, lack of appearance, and so on. So what are the effects of suicide? When a suicide happens, it has a ripple effect. It affects the family, it affects the friends, it affects the community. The loss is very sudden, it's unexpected. And actually, if you really look at it, majority of them would have communicated their suicidal thoughts to somebody. We always say suicide is almost always never a surprise. But for the other person, it is an unexpected person. And the reaction is anger. How can he or she do this? Why did you do it? Things like that. And also guilt, regret, and all that. So this is a kind of a checklist which is there for the institutions, whether you are able to provide crisis intervention and mental health support for a student. I thought I'll spend a few minutes on this, but I see that I'm running out of time, so I will not go too much into it. But this is a public, you can share this and you can see whether, how your institution fares in terms of supporting a person in a mental health crisis or suicidal crisis. Finally, if you have to have one slide to see what are all the factors and what are all the interventions which can be done to reduce suicide. On one hand, you have the genetic and epigenetic factors. Now there is talk of biomarkers to understand this. Then there is childhood adversity, and then you have family, parent-child relationships, then family functioning, personality traits, mental disorders, and previous attempts. These are what we call as mediating factors. And for that, we have all these brief psychotherapy, pharmacotherapy, community-based intervention, social work. And then you have what is known as precipitating factors, which are interpersonal conflict, bullying, cyberbullying, exposure by media or other through friends, and availability of means, for which we need to have restriction of access, which is a public policy, and social awareness. So if you are able to put in these many interventions for these many factors, many young suicides can be prevented and many young lives can be saved. So what can we do about this? At the home level, at the individual level, we have to teach young people resilience, emotional regulation, ability to problem solve, particularly interpersonal problem solving skills. And the most important, according to me, skill which we need to teach the young people is how to handle a failure. You know, how to handle a problem, how to handle a failure. If you are able to teach the youngsters how to handle a failure, then resilience builds up. Then at home we have parenting practices. Okay, at the community level, connections. Nowadays, many people, youngsters are connected, but connections are not there. They are connected to a lot of things, lot of people. They have 100,000 virtual friends, but you need somebody to lift you up when you fall down next to you. So they have, they are connected. They are connected with a lot of people, but connections is not given importance, and that needs to be done. Okay, and at, uh, at the societal level and the global level also, we need to, how do I say, we need to give young people that this world is worthwhile to live, worthwhile to contribute, and worthwhile to be of help to others. We define mental health as a state of well-being in which a person is able to realize his or her own potential, is able to handle the normal stressors of life, is able to work productively and usefully, and is able to contribute to the community and society. So if you are able to facilitate the students in all this, I am sure many young lives. Thank you very much. I hope I have not taken up too much of my time. I'll stop sharing. Is it fine?
Thank you
I'll
so
stop
much.
sharing.
Yes, that's good. Yeah, thank you so much, Dr. Lakshmi. It was extremely insightful and revealing presentation. Lot of things we think about suicides or misunderstandings, and I hope that your presentation will clear lots of issues and provide insights for educational institutes to frame policies to sort of prevent suicides in educational circumstances. Now I would like to invite Dr. Abhay Matkar. Dr. Matkar, could you please share your slides? Okay.
Is it okay?
Yeah.
Is it okay?
Yes, it's coming. Yeah.
Okay.
Just 1 second.
Yeah.
Just 1 second. Hold on for a second. Okay. Okay. Now I have. Yes, please go ahead. Yeah. So, Dr. Matkar, it's over to you. Can you make it full screen, please? Yeah.
Now is it okay?
Just 1 second. I'll tell you one. Yeah. Now it's ready to go. Yes. Thank you.
Okay. Can I start?
Yeah, please.
Can I start? Yeah. Thank you. At the outset, I would like to congratulate Indian Institute of Science for being the best university in the country. I would like to thank Indian Institute of Science for welcoming me to deliver a talk on this important topic. I would like to thank Dr. Bide especially for roping me into this. Actually, Dr. Lakshmi has already spoken most of the issues per se in this particular talk. I would like to thank her. I would like to thank my co-panelists, Dr. Ghorpade and Dr. Vyjayanthi. As you all know, 10th September happens to be the day wherein we get together and come together and address this important worldwide issue of suicide. We have a theme every year. Like last year, the theme is again the same this year, that it is working together to prevent suicide. It is well understood by this term that it's not actually a medical problem. Suicide is a symptom of personal suffering and needs evaluation, that is assessment, and care, not just by the medical profession, not just by the society, but each and every one of us. I felt I'll address this particular issue in three-pronged ways. The first one is there are certain myths which need to be addressed to, and I felt we need to address those and find out what is the truth behind that. The second one is how best you and me as a non-medical professional assess a patient or a person who has suicidal ideation. The next aspect is how best we can help each of these individuals. So what are the first few myths and facts about suicide? The first thing is people who talk about suicide will not do it. This is very important for all of us to know that the fact is all these people who tend to talk about suicide, their talk needs to be taken seriously. The second thing which is a myth is that suicidal people are crazy. The fact is most are insane, not insane, I am extremely sorry, most are not insane. That means they don't get prototyped into any psychiatric disorder per se, but more often than not, there are stressors which are present which lead them to this suicidal ideation or a suicidal act. The third myth is no one can stop a suicide. Now, this is something which is very important for all of us to know. As I just gave you a small preamble, that suicide is a symptom. It's a personal suffering due to a social cause too. So we need to know that we all can help one to prevent suicide. The fourth myth is suicide attempters are not willing to be helped. Now this is again important because like just Dr. Lakshmi said that they don't want to be helped. No, it is not so. The fact is it is basically a cry for help. The next myth is talking about suicide may give them ideas to die. This was one thing which I had grown up into before I entered into my psychiatric professional life. I felt that if you ask somebody, they might end up attempting it. But through the years, and data also definitely shows that discussing it openly does help our individuals. The next myth is suicide attempters are attention seekers. The fact is, it could obviously be a genuine cry for help. The next myth is suicide is impulsive, happens without warning. As again, Dr. Lakshmi has just covered, most would have some psychiatric disorders. Impulsivity would be seen in a few of them. They do give some verbal and behavioral messages, which usually precede days, weeks, and months before the final act. Suicide attempters really want to die. No, ambivalence is present. This is seen in almost 1/3 of the people, and it is more likely to be seen in the youth. So it's more likely to be a cry for help. The next myth is suicide attempts do not recur. We have seen that almost 25 to 50% of them recur in even less than 1 year's period. So a recurrence is common. The next myth is suicide is hereditary. While family history is important, not all suicides have a family history of suicide. The last myth which I thought I will cover is that children can't think of suicide or don't commit suicide. It's not so. Child suicides are possible, though rare. And the youngest patient whom I have seen in my practice was 4 years of age. Having seen a few of the myths, let us next get into what are called as the warning signs and how to identify a suicidal person. The first and foremost thing which you can observe in your friends, colleagues, or your family members is that that person tends to be withdrawn. there is a likelihood of a diagnosed psychiatric illness in that particular individual, which the person may or may not have shared. To do with alcohol and substance use. They either make a fresh beginning just before attempting suicide, or we see that they get into the phase of dependence or go into experimentation of newer type of drugs per se. An usual change in the personality in the form of symptoms of depression, anxiety, anger would also be seen. What is observed by few of the friends or family members is something that there is a change in the eating or the sleeping pattern. It would either be increased eating or reduced appetite, or it could be hypersomnia or insomnia. An important harbinger of the present suicidal
Dr. Matkar, I wonder if there is an internet problem here, or is it mine?
Even I'm not able to see.
So it looks like Dr. Matkar's connection has dropped. We'll get back to you next. Let's wait for a minute and see what happens. Dr. Matkar, you're back?
I am back, but where is my slideshow? There is no PowerPoint.
We request the audience to just hold on for a second. There has been some internet connection problem. Dr. Matkar is back now. We will be back with his presentation in a couple of minutes. Can you do the screen sharing again, Dr. Matkar?
Yes. Any idea where it could have gone wrong?
It's not visible right now. Okay.
Should I rejoin?
No, we are able to hear you and all. We just need to share your desktop. Can you share your desktop, please? You're not able to see that share button. So I have a feeling. I wonder if it's some network.
Wait. Yeah.
What? Example. Wait. John. You did this?
Stop sharing.
Again,
Open share.
You
This
share
one.
the desktop. No, you share desktop. Yeah. Okay, now you've opened it.
Yeah, Dr. Matkar, can you unmute yourself, please? Can you unmute yourself, please, Dr. Matkar?
Yeah, can you hear me now?
Now I can hear you. Can you just share your slides? Or show your slides? Yeah, yeah. Can you make it full screen?
Is it okay?
Yeah, that's fine now.
Okay, right. I'm sorry, the glitch. It was a major loss for me too, a short while ago. Right. We just talked about something to do with the family history of suicide, which is important, but it's nevertheless the only important thing. Madam just talked about something to do with the sudden desire, action to tie loose ends, writing a will, giving away of favorite things, and suicidal notes. These are harbingers of forthcoming suicidal actions. There's always a feeling of worthlessness in these individuals, helplessness, and loneliness. Individuals who have chronic long-standing ailments, be it something related to the heart, it could be malignancy, or chronic pain of any nature, they are the one who are likely to harbor suicidal ideas. Individuals who repeatedly mention about death and suicide need to be taken seriously. So the next part I felt, a short one of course, is something to do with the assessment of risk of suicide. How does one go about it? An important thing is one needs to assess the current mental state. That means what is the thought process of an individual about death and suicide in particular. Are there any current suicide plans? Have there any means, a time frame to end one's life, any exact plans? All these things need to be looked into. Along with that, one needs to assess the person's support system, which is very important in the management per se. Be it parents, it could be other friends, or any emergency contact numbers which we need to be aware of. So how can one help? How can we all help these individuals? As again, Madam has just talked about something too, is active listening. Now, one of the most important things which we come across, especially in youth, is that they tell us that we are not given a patient listening. So this is something, as a person who is likely to help these individuals, one should have active listening as an art. The questions which an individual can ask these attempters or those who have got plans, it could be either open-ended or closed-ended question. To understand the patient's suffering and the plans per se, one needs to go into the area of paraphrasing too. Most of the patients, as we just saw, are withdrawn. So we need to encourage expressions amongst these individuals. We need to acknowledge their feelings, because more often than not, they say that our feelings are not understood by the caregivers, the family, or the society. We also need to validate their feelings. So how can you manage a suicidal person? I have arbitrarily divided them into having a low risk, a medium risk, and a high risk. So low risk is somebody who has got some suicidal thoughts and no plans as of yet. So what can one do? One needs to offer emotional support, work through feelings, make an individual reflect on what is going through and what is the best option available, that is focusing on the person's positive strengths. Refer to a mental health professional if you feel overwhelmed. So don't feel that in case he is having more problems, you can solve it yourself. Do seek help. And these individuals need to be met regularly and they have to be in constant touch, so that not only are going to avoid a subsequent suicidal ideation, you are planning to get him back to mainstream at the earliest. What about those individuals who have medium risk? That means they have suicidal thoughts and plans present, but not immediately. One needs to go through the earlier steps 1 to 3 and also focus on their mixed responses and strengthen the will to live. We need to explore alternative to suicide. Why this is important is an individual who has gone through this ideation or plan feels that there is no other alternative except to end one's life. A contract is very essential to make, and one needs to extract a promise or a bargain from an individual who has planned suicide. Referring to a mental health professional or a doctor, if none of the above helps, is again important. What about high risk individuals? These are the individuals who have definite suicide plan present, has means to do it, and plans it in an immediate time frame. One of the most important thing in this particular area is that one needs to be with the person. That means one should never leave the person alone. Gently talk to a person, remove any means from this particular person, make a safety contract, contact a mental health professional doctor immediately, arrange for an ambulance and hospitalization. And one needs to inform the family or other significant caregivers in these subset of patients or individuals. What are the simple things one can do? Again, coming back to something which we talked about is to listen, show empathy, and be calm. Be supportive and caring. Take the situation seriously and assess the degree of risk. Ask about previous attempts. Explore possibilities other than suicide. Ask openly about suicide plans. Buy time. Make a contract. One needs to identify other support systems, be it family, friends, or the like. Any means which are likely to perpetuate a suicidal attempt needs to be removed. One needs to ensure the safety of an individual, and again reiterating a fact that one needs to stay with this particular individual. What you should not do, these are also very important for all of us to know. An important thing which we come across is, these are a few things which we have learned over a period of time through our clinical practice, is that one should not ignore the situation. Don't get panicky or embarrassed. Don't give false assurances to these individuals, but do enter into a practical contract with these individuals. Don't dare or challenge. Now, this is something which we see often in the youngsters, either parents telling the children or vice versa, go ahead and die. That should not be the case. Don't trivialize their problems or their pains. Don't get swayed into secrecy. Again, reiterating a fact, don't avoid or leave them alone. As a friend, what can you do? Take all talk of suicide seriously. Get involved and use active listening. Recognize warning signs of depression. One of the things which you all need to know is that not all depressives are suicides, and the cause of all suicide is not depression, but a significant number of individuals who have what we call it as major depression do have few symptoms of suicide. Don't be afraid to ask about suicide. Again, as we just talked about a myth that talking does not precipitate a suicidal act. High-risk individuals should never be left alone. Get help if attempt has been done or the situation is overwhelming. To conclude, a little compassion, commitment, sensitivity, knowledge, and concern for another life, along with the strong faith that life is worth nurturing, will go a long way in bringing back a distressed life from the dark vortex of suicide. Let us save lives. Thank you.
Thank you very much, Dr. Abhay Matkar. You covered very simple yet very important points, dispelling various myths. That was really instructive. So now it's time for panel discussion and question answers. So what I will now quickly do is I will introduce 3 panelists in addition to the 2 keynote speakers that we have today. And then once I do that, I will take up questions. Okay, so I would like to begin with Dr. Ajit Bide. I'm going to keep it short because many of you who attend IISc events are familiar with these people. Dr. Ajit Bide is an extremely important person who has been advising us on the IISc Wellness Center for more than several years now, and especially since the formation of the IISc Wellness Center last year. Thank you again for joining us. Next, we have Dr. Ghorpade, who has been a consulting psychiatrist at the IISc Health Center, and it's very valuable to have him. To have his perspectives today. Thank you very much, Dr. Ghorpade, for joining us. And then we have Dr. Vyjayanthi, who is also a consulting psychiatrist at IISc Health Center and IISc Wellness Center. Thank you again for joining us for this panel discussion, and all of your insights will be extremely helpful to go through the questions we have from various audiences. We have a lot of questions. I will begin I would like my first question to Dr. Lakshmi. Dr. Lakshmi, when I complete the question, I request you to unmute yourself and please speak. So the first question is, why suicides should be prevented? If someone wants to die, what is the problem with that?
The fact is, most of the people who die by suicide are not sure they want to die. Okay, the major emotion of a person, 80% of people who die by suicide are ambivalent about suicide. They really don't want to die. If you talk to them, most of them would say, it's not that I really want to die, but I cannot go on living like this. Okay, and that is a major factor. The other factor is, if anybody who has suicidal ideas, if you are allowed to die, we would not have Robert Clive, we would not have many other people whom we read about in history, books, or made tremendous contribution to this civilization, like Abraham Lincoln, Winston Churchill, you name anybody. Everybody have had suicidal ideas and suicidal attempts. So the fact is, most of them really do not want to live. There is a small proportion who are very set on death, and nobody can really prevent. But fortunately for most of us, 80% of the people who are suicidal are ambivalent. The next thing is, 80% of the time, the suicide which happens is often what we call as a permanent solution to a temporary problem. It's a time-bound phenomenon. Okay, one cannot feel acutely suicidal for 6 months. It is against our physiology to do that. Okay, we are acutely suicidal for 2 or 3 weeks, and at the end of 2 or 3 weeks, either we attempt suicide or we come out of it. So if support is given at that point of time, suicides can be prevented. The third thing is, many of us forget what the suicide leaves the other people in the family and friends with. Forever till their own death, the question of why, guilt, what have I done, why has this happened, what wrong have I done, how could I have prevented? So the one death actually causes living death of many people. Okay. So these are all the reasons why suicide should be prevented.
So the next question is, I will direct the next question to Dr. Abhay Matkar.
Okay.
A person may feel he or she may get relieved from the pain of constant anxiety or depressed state of mind if he or she ends the life. But at what stage does the person actually attempt to do that?
Okay. Am I audible?
Yes.
Yeah. See, now basically one needs to look into the statistics per se, which will help in understanding the symptom complex of anxiety or depression. Worldwide, or let us say even in India, about 10% of the people suffer from depression, out of which major depression, that is severe form of depression, accounts for only about 1%. And out of that 1%, 10% attempt suicide. That means suicidal ideation per se, which occurs in the phase of depression, is at one end of the depressive suffering. That means depression which is very severe, long lasting, and not at the earlier phases of life. Now, why one tends to go through these various phases of anxiety or depression is because one has not introspected oneself into the positive attributes one has also not attempted to seek help. And this help is basically not somebody from the professional per se. It could be from a friend, could be colleague, or it could be a close family member, and then of course a doctor. So it's a long journey. If you want to cut it short, speak to someone, seek help, and that's going to solve your problem.
Can't hear you. Vishu, you need to unmute.
Yeah, now I have. Yes, sir, that just done it. Yes, yeah. So third and fourth questions, I will go back to the keynote speakers again before I go to the other panelists. So Dr. Lakshmi, this question is to you. So how does the 3 C's factor play a role in suicide? 3 C's meaning class, caste, and color. As I see, there is a strong correlation with discrimination. How to create supportive egalitarian community groups within campus?
That's a question which all of us have to ask ourselves as an individual, community, and as a policy, as the government. Anything which causes discrimination, anything where there is a shame, and anything which causes stigma, actually it produces suicidal ideas. On the other hand, if you really look at it, how do I say that? Let's take, for example, this, because I don't want to take an Indian example, let's take the US, okay? Now, the blacks are repressed, they have low socioeconomic status, they have low educational status. But if you really look at who has the highest suicide risk there, it is a middle-aged, white, educated male. Okay. Or for that matter, if you take India, the southern states are supposed to have better GDP, better education, better standard of living. And we have the highest suicide rate when compared to Uttar Pradesh or Bihar. Okay. So it is not the economic prosperity which determines suicide. See, the problem is we have looked at it, why this is happening. When we are able to blame an external factor for our failures, we are able to handle the failures well. Now, if you are educated, successful family, everything, but that still you are not able to achieve the so-called success, then you have to accept it as a failure. So there is no one reason for suicide. First, I want to say that a lot of things have to go wrong for a suicide to happen. So we have genetic vulnerability, biological vulnerability, predisposing factor, precipitating factors, and triggers. Okay? All these have to combine at a different level to cause suicide. And even if you have all these factors, one protective factor, like a very good friend, or a strong religious belief can help you to counter that also. So it is like a kind of a jigsaw puzzle or a push-pull thing, and you don't know where the knot is at that point of time. Okay. So in terms of class, creed, and color, if you look at our statistics, unemployment, poverty ranks only 6th in the cause of suicide. The first cause for suicide is family problems. So in our society, it is the interpersonal issues which causes us a lot of problems. Okay, family, unemployment, debts, all comes in the 5th or 6th category. Okay, in terms of caste in India, we did a kind of a study to find out whether it is not yet published. So just I would like to say it as a context, because the NCRB does not give caste in the list.
Okay.
So we had to actually have an RTE and get the data and analyze it. But we wanted to know whether people from scheduled caste, scheduled tribes have higher suicide rates, and we didn't find that. But what we found was what we call as a minority. For example, if that state has a majority one caste and there was another caste is a minority, the minorities had a higher suicide rate. Okay. In states where it is more equitably distressed, it is equally distressed. So it is more in a society where you feel you are a minority, then there is a higher risk. For example, states like let's say Chhattisgarh, which has quite a sizable number of scheduled tribes. There is no difference between the other people and scheduled tribes. But if you take a state which has a very small number of scheduled tribes, then so it is more the societal, what shall I say, goes back to the Durkheimian theory, how integrated you are into the society, which determines suicide.
That's clearly the role. There are many multiple factors and a complex set of factors that play a role in suicide. So let me, the next question is to Dr. Abhay Matkar again. Could you please unmute yourself? And this is about, this question is as follows. Suicide is considered as an irrational response to the stresses of a rational society. But why are the stresses that the society imposes on an individual considered rational? Why is something considered rational just because it is necessary? This person goes on to give examples. Exams, interviews, evaluations, etc. are treated as rational ways of treating a person because they are necessary, thereby labeling us to believe that anxiety, stress, or suicide they cause are irrational. Yes,
okay,
sir.
fine. It's the longest question, but what I understand by this person's question is the whole issue of rationality and irrationality stems from this subjectivity, basically. So what he feels rational, the society would otherwise think, or vice versa. Now, we need to have in our society something to quantify. And the yardstick for quantification is something what we call it as examinations. We have examinations right from the school level, we have it at the university level, and what you know. So these yardsticks are something which are established because they are quantifiable. So we cannot go away from the so-called term of getting from rationality to irrationality. They are set norms of the society. The norms do not take up into consideration the words rationality or irrationality. Norms follow something which is to be taken into consideration for the maximum number of people. That means this level is something which is going to do good for the maximum number of people. And that is why we have this something called as interviews, and you have more of subject. Now, what I would like to do is maybe a little extension on this particular issue is, as youth, what we have seen most of the people is, they tend to have only black and the white lines. Over a period, what I want all of us to develop is that there is a lot of gray area, which we have to move around. And that comes through a term, what I would call it as flexibility. I would not like to stem on these words like rationality or irrationality. I would like to use the word flexibility, in which most of these domains come into, and then you are able to give the best out of yourself and come out successfully, rather than through a negative feeling of what is just described as anxiety, depression, or suicidal ideation or a plan. Okay.
Vishwesh,
Can
Vishwesh,
unmute.
mute.
Sorry, I would like to request Dr. Ghorpade to address this question. Are you able to hear Dr. Ghorpade? Can you
I
unmute
don't
yourself?
think so. He heard the question.
Can you unmute yourself?
Yeah. I'm able to hear you.
Okay, now I can ask the question. So
Go
this
ahead.
person is asking, sometimes I have suicidal thoughts, but I do not know if I am depressed or do I joke about it. I feel lonely at times, and I end up wasting my day thinking if it is worth living life like this. Most days are fine, and lately I have had anxiety that I could not hide, and I'm seeing a therapist. Am I also clinically depressed? That's the question.
See, this is a very tricky question. The diagnosis of depression, according to some of the standard methods, they may not be depressed, but clinically, when you see them and they take their view about life in general, definitely they fall into the category of depression. Initial hiding of depression may not be detected, but later when he realizes that he is depressed and seeks help and wants a label to be attached to him, probably I think we will be very comfortable to tell him that he is depressed. There's no doubt about that.
My next question is to Dr. Vyjayanthi. Can you unmute yourself, please?
Yeah.
Thank you. If considering ending one's own life, how can he or she convince to stay motivated and move forward past the loneliness and pain? How to avoid one's deep negative thought, which constantly gives an idea of suicide? The key reasons for himself or herself being emotional detachment from everyone, including family, friends, etc. And this affects the professional goals as well. How to deal with this? Please provide any suggestions.
Well, this question is actually posed as if the person has no clinical diagnosis, though almost every feature of depression has been outlined. Okay, social withdrawal, lack of ability to communicate with others or connect with others, except for biological functions. Almost all the social functions of this person has been impaired, if I were to say it as a psychiatrist. Now, if I have to consider this person to be, as he thinks he's normal person who wants to be motivated despite having suicidal thoughts, I think his very definition of normalcy needs to be changed, because you can't be entertaining ideas of suicide. You can't be not feeling connected to anybody. You can't be not productive in your work and still want to work and be productive. These things don't go together. So there is definite discrepancy in his very question itself, one aspect to the other aspect. So all I can tell is, if a person has been treated for depression, has already under supervision for suicidal ideation, how does he motivate himself? If that is the question, there is a different answer to that, because part of it could be medication, part of it could be psychotherapy, part of it could be occupational therapy. There are different people to assist you in each of these endeavors, and you can't do this all alone by yourself. And I'm not a guru to give you an advice all by myself for this one aspect. How do you motivate yourself when you don't feel connected to anyone at all? Next to impossible, no? I mean, it's only to please yourself. How is that possible? So I think that every aspect of this question points towards depression. But the person is not accepting a diagnosis of depression. It's okay what you label it. As long as you think it's a problem and you're willing to seek help, yes, we can help you. Is all I can say.
So, is it fair to say that this person must certainly consider visiting a therapist,
Yes.
psychiatrist for evaluation, if not already being done?
Yeah.
So, then my next question is Dr. Bide. So, the next question is posted in the Q&A session here. I had a recent discussion about suicides with my parents, and the first question they posed was, why would someone suicide? I think many people have the notion that someone committing a suicide is a very rare occurrence, which makes them less sympathetic and less sensitive towards those committing suicide. How can we tackle this?
I'm not sure I understood the question.
So the question is, this person had a discussion with the parents about suicide.
And he found his parents unsympathetic?
Unsympathetic towards somebody who commits suicide.
Right. If you remember Abhay's slides about myths about suicide, the first notion is that this is something very strange. If the guy is crazy, these kind of notions prevail. Actually, there is deep anguish over here, and it's sad that the parents are not able to recognize the anguish. I'm presuming that when this person discussed suicide, it was his own thoughts of suicide that he shared with his parents. And I think this person must not go only by the parents' judgment that this is weird, this is rare. It is rare. Fortunately for us, suicidal thoughts actually enter every intelligent mind at some stage, but they're warded off. Our healthy defenses within ourselves help us to ward off this thought of self-annihilation. Sometimes they take a deeper root because of the multiple stresses that you undergo. Dr. Lakshmi Vijaykumar very clearly pointed out, it's not a single factor that brings this about. When there are cumulative factors, the chances of somebody yielding to suicidal thoughts is much greater. So each of those causative factors, precipitating factors, needs addressing. And for this, it is ideal to get in touch, especially for a person who has a bad support system at home, to contact your health center or somebody, a mental health professional, to seek help. Because the family might do a lot of damage. The intention may be good, but they say the path to hell is paved with good intention. We have to be very, very cautious with a not poor support system that health care systems should be available to this individual to sort out the problems. Please don't waste time. Please get in touch with either the doctors at the health center or with a mental health professional.
So again, this is an advice to the person who posted this question to consult mental health professionals.
I think I suspect that is going to come up very often.
Yeah, I would think so too. Yeah. My next question goes to Dr. Lakshmi. So now we have a bunch of questions that broadly relate to suicides and education institutes. All places and everyone has personal problems. But why is the suicide rate high in premier institutes like IITs, IIScs, and other higher educational places in comparison to other colleges, thousands of colleges? Is it only an Indian phenomena? Is it also true across the higher education sector in the world?
Actually, about 4-5 years ago, the Union HR Ministry constituted a committee to look into suicides in IITs and other higher technical institutes. Professor Ananthakrishnan, who is the chairman of the IIT Nagpur, IIT Kanpur, was the chairperson, and we had a few of us were members, and we actually went to Kanpur, Delhi, and Chennai IITs to talk to students, and we gave a report to the central government on about the suicide and what needs to be done to handle this. Now, to essentially say this, if you look at the suicide rate per se, it is not different from other student rates in other institutions, the premier institutes. But the fact is, we did find that the students who died by suicide in the premier institutes came from slightly a background which came from a rural background with a limited language ability, with even if they are smart, not really recognized by the peers. And the other factor which we found was that these people who got into the premier institutes, when exactly the suicide happens, it happens after the first year, or actually many of them do it in the postgraduate years. Okay, and in the factors are different. When it happens in the first year after the first semester or second semester, it's usually a person, as I said, who come from rural areas with limited language ability. And most of these students who have gotten into IIT have been a bubble. For 2 years, they have not done anything else except study for IIT. Okay, they are in either quota or these training institutes or that. So they have lost connection with reality. They have lost connection with people. They are totally in a bubble. And then they go into IIT, and mostly it is free. You are welcome to do what you want, come to school, class, no attendance, things like that. Okay, that is a major issue. The second major issue we found was the IITs have we didn't come to IISc, I don't know why, because it was all technical institutes, but I don't know, but we had all the other national institutes partaking in this survey. The other thing was the grading system. Okay, you could have scored 95%, but still you are in the lowest rung of the class, and that hurts a lot of people, and they have a tendency to put it in the notice board. So one thing we were able to recommend and challenge, except IIT Kharagpur, which gave the absolute marks, the rest of the IITs, it's a grading system. So even though you have got 95%, you'll still be in the bottom of the class. And it is put in the notice board. So we had recommended that all these notice board things should stop. Okay, and that they must have a bridge, that every student who enters these technical institutes, for the first 2 weeks, they should have a kind of a bridge course where people are identified and talked about, and help them to go through this process. The second thing which we did was the peer support. IIT Kanpur has developed a fantastic peer support where they are able to identify students who require help, and they kept it next to the library so that it is not that people don't watch you going to a psychotherapist or a counselor and feel stigmatized about it. So I think it was a very good system. But honestly, if you really look at it in terms of numbers, the number of students in IITs who die by suicide is more or less similar to number of students who die in other institutes also. The fact is, a student dying in IIT is media value. Media goes, why is somebody who has worked hard, got everything which the other people want, why should they die? That is the psychology behind that. But I think it is the fierce competition, the grading system, and from a bubble to a total freedom. And we also found that many of these autonomous institutes, the teachers or the lecturers or the professors have undue powers, particularly for PhD. If you got a guide who really screws you, then your life is gone. And that causes a huge amount of pressure. So some departments I know, I can identify, I don't want to name it, some departments in some IITs, we found that those students had more attempted suicide. So because the complete power the staff or the professors or have on the future of the student is quite something. So these are all the factors. But as such, I wouldn't say that IIT or IISc has more suicides, but it is more known outside because of the fact that you are in IIT or IISc. Because you have everything going for you, and then it is like celebrity suicide, right? Everything is going for them. Why do they end up in their lives? That's the.
Yeah, that's very important to know, interesting to know.
One
There is
thing,
a general perception that students in primary institutes are more likely to.
Viju, can I add to that? Can I just
Yeah,
add?
please go ahead. Yes.
Since Lakshmi brought up quota, the number of suicides among young students who are drafted into quota, it's almost like an army draft. You have no choice. You have to go and recruit yourself over there because you'll be coached in a very high intensity situation. And there are a number of young people who can't tolerate that kind of a regimented life. The quota has a very high suicide rate, particularly certain institutes within quota. I think we're aware of that. The other thing that happens in an institute like IISc or IIT is most of the people who come in have shone in their earlier days, whether it's at the PUC or the high school level, they're the toppers of their class. And suddenly you're in the middle of a whole lot of toppers. There's a lovely Subhashita in Sanskrit which says that one lotus in a lake will shine. But if you have a lake full of lotuses, nobody notices the lotuses at all. This is what happens very commonly in my contact with IISc. This is what I've encountered. People who were admired in their local places no longer have that adulation which they were so used to. You come here and you're just an ordinary person over here. And that causes a big beating to the young person's self-esteem. I think that also pulls them down.
Thank you. My next question is to Dr. Matkar. Can we really prevent suicides? Because this relates to your presentation. Are these sessions really helpful? Yeah, this person who is writing the question refers to a recent suicide on the campus. He says that person looked completely fine, never showed any symptoms of having any depression or any other problem. His friend used to meet him regularly. They regularly had conversations, but he still never shared anything. He never let the person know what was going on in his mind. Can we really help anyone around us?
Okay, right. Thanks for this question, because this is where we go back to the first we talked about that suicide is preventable, and working together will help in preventing suicide. Now, how this can be done is basically, as Madam has already talked about, we need to look into all the causes of suicide and we need to address most of them. That is one aspect to it. The second thing is this particular friend having not picked up the signs, we call some of the features called as soft signs. So-called some soft signs may not have been picked up, and that is why possibly he is feeling guilty about not having picked up those soft signs. We also have this tendency to meet friends in the best of our prime times and the best of our records. That means emotionally we want to be at our best when we relate to our friends or colleagues. And that too, it's for a pretty short period of time, during which time he or she may not have read the other person's angst per se. So maybe those are the things. So one needs to look into many dimensions. That means we look into not just the educational aspect, the social aspect, and a few more for a pretty longer period of time to judge a person that this person might go into suicide per se. Whether these talks do help, yes, I do feel, because though we are addressing to a large number of people online, I do see that there are a lot of students and the staff also who tend to follow up these, and there are a significant number of people who do come back and tell. They may not tell Dr. Ajit Bide, but they will tell me and say that the talk which Dr. Ajit Bide or Dr. Lakshmi gave did help us, and we did make some modifications in the life also. One critical example which
I think the network seems to be lost again, right? I can't hear Dr. Matkar.
No, we can't.
Ah, now we can hear you back. Yes,
Can you hear me?
please. Yeah, now we can hear you. Yeah, go ahead, please.
This follows the old thing, you switch off and then you switch on. I think you come back. No, what I wanted to talk about is something which Dr. Ajit and Dr. Lakshmi have already spoken about. Is one of the case which was just discussed, that the parent not addressing to the psychological need of the person per se, but just trying to talk about one of the feature of that so-called depression, anxiety, or what you have. As I just told you a short while ago, suicide is a symptom of an underlying problem. We need to address that. And if we are able to address that, I'm sure we will be able to come through in better colors. This is one aspect. The second thing is there are preventive measures. Dr. Lakshmi just started talking about it, and I don't know whether there would be a question later to that. I would like to sum up on this issue as far as institutions are concerned, which we tend to do in my institute, is that we have a 24-hour helpline for all such events. We have an active 24-hour helpline, which has helped a lot of our students and staff too. This is one aspect. The second thing is small group mentorship has also helped in my institute. The third thing is a third party, that is an individual who is not teaching a particular subject, has an open house discussion in the hostel with a select few students as to understanding the problems of concern to them. And it need not always be something to do with studies. It is something that we found that somebody has come with a substance use. We do not stigmatize people who have of anxiety or depression. So this is another way how best we can the level of suicide, because it doesn't come off one single night per se. The whole issue of anxiety, depression, stress goes through various steps. And if we are able to help them at these steps, I'm sure we'll be able to prevent suicide.
Thank you. So now I just want to pose this question to everyone. So we are 5 o'clock right now, 1.5 hours from the time we started, and we have not many more questions which we obviously cannot take. So can you suggest a time deadline that we should stop? Dr. Lakshmi, Dr. Matkar, you are the guests today. Could you tell us how much longer should we go? What do you recommend?
I'm okay with half an hour. I'm more busy.
I'm sure you have commitments.
I am afraid I have to leave in 5-10 minutes.
Okay. Okay. So I think,
questions to her now and later.
Okay. So we will have maybe one last question to Dr. Lakshmi. Then is that fine? Because we did promise only up to 5 p.m. To audience as well. It's already close to 5 now. Okay. Is that fine? So we'll take one last question, address one last question to Dr. Lakshmi. This is a general question again. Are creative pursuits, like including research, more likely to cause depression, and when it exceeds a breaking point, also a suicide? The reason why I think that could be the case is that results and successes are not guaranteed in creative pursuits and in research of any type, and therefore, but we still have very high expectations of ourselves, that we want to really perform very well, but there is no guarantee of it. So therefore, basically, is a higher education institute with a focus on research just more likely to have more events of depression? Earlier questions, but it talks about research.
Actually, whether researchers have more suicides or not, what has been found is that people who engage in, see, there are two questions here: creativity and research. Yeah. Okay. Now, we do have evidence to show that creativity is linked to mood disorders. Okay, there is a genetic kind of a relationship with mood disorders, and if you are likely to have mood disorders, you are more likely to attempt to die by suicide. So there is an indirect connection between creativity and suicide attempts and suicides. We have many instances of famous painters and authors, and starting from the actresses and things like that, like Marilyn Monroe, Ernest Hemingway, Van Gogh, so many people. In terms of research, actually we have not found more researchers doing it, unless we find researchers who die by suicide or make an attempt. They make it after 3 or 4 years into research and find that their research is not successful, either to them personally or to the community. When they feel futile, that they have wasted 3 or 4 years of their life in this with no discernible outcome, positive outcome, either personally or to the society or to the knowledge, that is when suicide happens.
Okay.
In fact, there is a module for researchers. I think it was developed by Caltech because they had a lot of suicide attempts there, where they say it is not the outcome of your research which determines your research. Okay, they changed the what shall I say? The endpoint indicator is not the outcome of your research, but the process. So even if the end outcome is not satisfactory, if the process is fine, then the research is accepted. And in fact, they were the ones who kind of brought out the importance of negative results.
So if I understood correctly, you are saying that the a delayed research performance and the sort of worth, the consideration of how what was the worth of the research, that does potentially have some impact on the suicide rates at a later stage of the research career, right? Thank you. So now, unfortunately, we have run out of time. We have lots of very, very interesting questions. We will sort of postpone those to a later section. We have a monthly Ask the Expert sessions that are run by students of IISc. So maybe some of these questions will be taken there. We will forward those questions to them, and they will consider maybe in some of the later sessions. So now I would like to invite Dr. Suja Elizabeth, who is a professor in the Department of Physics, and she's also a member of the Wellness Center, to come online and give a vote of thanks to all of our speakers and panelists today. Over to you, Suja. Okay.
Vishu, I'm audible?
Yes, you're audible. Yes.
Thanks. It's my pleasure to propose a vote of thanks on behalf of IISc Wellness Center before we wind up today's panel discussion on prevention of suicides by renowned experts in the field. In her presentation, Dr. Lakshmi Vijaykumar from Sneha, Chennai, has given many good insights to various ways to prevent suicidal instincts and such thoughts. This was also followed by yet another interesting talk by Dr. Abhay Matkar from SDM Medical College, Dharwar, on similar lines. I express my gratitude to both speakers for giving us many useful tips and insights, and also for participating in the ensuing panel discussion, which was quite interesting and informative. Let me also thank other panelists. Dr. Bide, a popular consultant psychiatrist in town, and he's also an important member of our wellness committee, and who always supports us. And then Dr. Vyjayanthi and Dr. Ghorpade are consulting psychiatrists for their active participation in the discussion. And their inputs and suggestions are in fact very valuable, as they are closely aware of the concerns and rather the pulse of our institute community. Quick to note that the panelists could address many of the queries and concerns raised by our students and campus community, though many are still left. We also acknowledge the efforts of Dr. Vishwesha Guttal in moderating the discussion and conducting the program so well. We should also remember the efforts of our student team, especially Nilay and Shekhar, in helping us to conduct this program so well. And before I end, let me thank all of you for participating and making the discussion interesting by posing very relevant questions. It is our duty now to disseminate the vital information we received today for the benefit of those we know and could not participate. Thank you.
Thank you very much. Thank you for the invitation.
Thank you all.
It was a pleasure to be
Thank you
part
all.
of this panel and privileged to be with stalwarts. And thank you for coordinating everything so well. And thank you very much. I'm sorry that I have to leave, but it has been a pleasure and a privilege.
Lakshmi, I must say that Vishwesh Guttal was the one who brought this topic up. You and Prabha were involved in a program, and we thought we should have you over here. Thank you for responding to my personal invitation, and Abhay, you too.
Thank you.
For responding. But the idea really came from Vishwesha, and we should never forget that. He's not the kind who'll ever talk about it, unlike me.
Thank you very much. And I'm sure by now Vishwesha would know that nobody ever says no to Ajit.
Ajit. Yeah. Thanks, Dr. Ghorpade and Dr. Vyjayanthi also. Thank you. Thank you.
Thank you, Dr. Vyjayanthi. Thank you, Dr.
Thank you, Lakshmi ma'am.
Thank you.
Thank you, Anil sir, if you're there around. Yeah. And thank you, Nilay and Shekhar.
For a good job. Yes.
Yesterday it was